So much, Heidi, and thank you everyone for joining the Spotlight on Women's Health Cyber Seminar Series. That is sponsored by the VA HSR&D Women's Health Research Network. My name is Dr. Adriana Rodriguez, and I'm the Program Manager for the Women's Health Research Network Consortium. We have some great speakers lined up for you all today. I have the privilege of introducing them. Doctors Suzannah Creech and Ursula Kelly, and our discussant, Dr. Jennifer Strauss. Just a little bit about them. Dr. Suzannah Creech is a research psychologist at the Central Texas VA and the VA Vision 17 Center of Excellence, and she's also an associate professor in the Department of Psychiatry at the Dell Medical School of University of Texas at Austin. And then Dr. Ursula Kelly is a nurse scientist at the Atlanta VA Healthcare Center and also an associate professor at Emory University Nell Hodgson Woodruff School of Nursing. And lastly, Dr. Jennifer Strauss, our lovely discussant, is the National Lead and Women's Mental Health Program Manager for the Office Mental Health and Suicide Prevention in VA Central Office. Really looking forward to hearing about all of your respective projects and the discussion led by Dr. Strauss. So let's go ahead and get started with Dr. Creech.
Hi, thank you so much for that introduction and for having us here today. I am absolutely thrilled to present to you these studies and on this topic. I think it was, maybe like 10 years ago, one of the evidence maps came out and there weren't a lot of randomized clinical trials in women veterans. And I think this presentation and some of those that you've seen earlier this year really speak to the growth in that area. So today we'll be speaking on two recently completed randomized clinical trials focused on improving mental health treatment engagement among women veterans with sexual trauma history. Our sorry, my computer advanced a little faster than I wanted it to. I'm going back to the slide I want you to see. Our objectives today are really to provide you with background and rationale for these studies, to let you know about our methods and results and sort of the implications and next steps, so you really kind of have a good understanding of these trials and their findings. And I don't think in this group that it'll be any surprise to you these sort of prevalence numbers on sexual assault among women veterans. In the United States, 21% of all women will be sexually assaulted in their lifetimes, and 24% of women will be sexually assaulted during their active duty service. That number grows to 38% for military sexual trauma when we include both assault and repeat experiences of sexual harassment. Among certain populations of our women veterans, the prevalence of sexual assault is even higher. So among bisexual women, something like 1 in 2 women experience assault in their lifetime, and rates among bisexual women, rates of assault among bisexual women during their military service are also higher, and they're higher among racial and ethnic minority women. And unfortunately, these are some of the groups that are less likely to disclose that the assault occurred, and that can work to interfere with care seeking. I think that this audience is also well aware of the consequences of sexual assault, which include myriad mental health symptoms and disorders, in particular PTSD, alcohol misuse, and the unfortunate phenomena of repeat exposure to gender-based violence, including repeat sexual assault and intimate partner violence. The consequences of sexual assault also include processes like stigma, shame, self-blame. You may have heard of rape myths, such as blaming the survivor blaming themselves or their, their apparel or what they were doing at the time, that sort of all of these act together to really inhibit disclosure that the assault occurred and care seeking. And unfortunately, we see some of these processes enhanced and magnified for some women veterans when they come in for care at VA, because our context can be perceived, potentially to be military-like, and so it can be reminiscent of the assault, or they can be faced with co-occurring care in an environment with persons like their perpetrator. So that can act as a barrier to care. And for our marginalized populations, these processes can be magnified and intersect with other experiences like institutional racism, homophobia, or betrayal that further act as barriers to care. And all told, there's a population economic burden of sexual assault estimated at $3.1 trillion over the lifetime of all survivors. And, for any one survivor, there's a substantial economic and other intangible costs, not just to themselves, but cascading through generations into their offsprings. So it's critical that we work to address barriers to seeking care when it's needed, to help address these issues. How are we doing at VA? In general, the data is great. We've closed many of the gaps in access, and our numbers of women who are receiving specialty care and so forth look great, but not for everyone. So overall, we're doing really well, but there is a subset of our women veterans, particularly those with sexual assault histories, for whom delayed care, attrition from care, and underutilization of care are still major issues. And this is in part due to those processes of stigma and distrust. And studies have shown that for some of our women who've experienced assault, they have concerns about provider compassion and shame and continuity of care. For others, institutional betrayal has been identified as a significant barrier to seeking care. They have 2.1 times greater odds of delaying or foregoing care when that assault occurred in the military. And even though military sexual trauma overall is associated with significant symptoms of PTSD or depression, it's not necessarily associated with mental health service use. In part because of these processes of shame and stigma, as well as mental health literacy that can inhibit care seeking. So there's a clear continued need to address these barriers to utilization and initiation of mental health care in these groups. And so now Ursula is going to talk a little bit about care seeking for particular conditions.
As soon as I can unmute. So probably everybody on this call knows that the VA is a leader in providing evidence-based treatments for PTSD, particularly trauma-focused therapies. So those therapies, specifically cognitive processing therapy and prolonged exposure, which are referred to as CPT and PE, are recommended as first-line treatments for PTSD by the DoD and VA, and those have both been rolled out nationally. However, we have a problem. So while these treatments are effective for as many as 3 out of 4 veterans, meaning up to 70% have clinically significant improvements in PTSD symptom severity in research studies, dropout rates are high. Studies show that they're 30 to 40%, again, in clinical trials. And what we see in real world practice settings is dropout rates as high as 80%. Even for those who complete treatment, so that's that green 49 to 70%, roughly 2/3 continue to meet the criteria for PTSD based on their symptom severity. So if we do the math and look at anyone who's willing to do trauma-focused therapy, 30 to 40% drop out, roughly 50 to 70% complete treatment, and 2/3 still have PTSD at the end of it. So we have these evidence-based treatments, but we're clearly left with a gap in effective PTSD treatment, really particularly in terms of engagement, treatment completion, and effectiveness. So complementary and integrative health modalities, CIH, might address some of these gaps. Researchers, clinicians, people living with PTSD, particularly in the VA and veterans, have been using CIH modalities more and more, like really over the past at least decade, if not two, for a wide range of conditions and symptoms, including PTSD and chronic pain, among others. Many of you may have seen in your own medical centers that CIH therapies are becoming part of standard VA medical care for several reasons. And this is a little bit of a digression, but I thought it would be helpful just to frame this a bit. The reason for this, there are many reasons. But in 2014, the Office of Patient-Centered Care and Cultural Transformation established the Integrative Health Coordinating Center, really to develop policy and build infrastructure across the VA for expansion of CIH services. That was followed in 2016 by CARA, the CARA Act, that mandated CIH provision and research be expanded in the VA. And then in 2018, the VA Whole Health System Transformation supported 18 VA medical centers to provide widespread access to CIH therapies. The reason this is a little bit of a digression is that these are not necessarily focused on particular symptoms or diagnoses. In some settings they are, in some settings they're not. At the same time, both in the VA and outside of the VA, there's been growing evidence for the effectiveness of CIH modalities, including yoga for PTSD. There's been increasing demand from veterans for these services. And what we do see is that women are higher users than men. And it won't surprise anyone to hear that the need for non-pharmacologic treatments for chronic pain due to the opioid epidemic have also been a driver of the greater use of these modalities.
Thank you, Ursula. So it's against that backdrop and background that we'd like to present to you findings from these 2 RCTs today that were conducted within women veterans who've experienced sexual assault. Before I get into the details of our study, I wanted to acknowledge everyone who made it possible. In particular, this study was embedded in our women's health clinic at the Central Texas VA at our hospital in Temple, and without their willingness to partner with us on this research, it wouldn't have been possible. And hundreds of women veterans who participated in various stages of this study that led up to the RCT. I'd like to thank them as well as my collaborators. In terms of disclosures, I'd like to note that this was funded by the Department of Defense, and in addition to institutional resources that we used, we don't have any other conflicts of interest, and of course I don't represent the views of the government. So the Safe and Healthy Experiences intervention is a digital health intervention at its core, and digital health interventions and technologies may have particular use and effectiveness in marginalized populations and for stigmatizing conditions because they can be delivered directly to the patient in a non-stigmatizing setting. So in our case, the intervention was delivered directly in primary care. In other cases, these interventions can be delivered at home. And the benefit and sort of the ideal is that within organized healthcare, these types of digital interventions might be used to connect to immediate referrals and other types of treatments. So the Safe and Healthy Experiences intervention, which we call SHE, is a modular intervention. It's about 20 to 30 minutes long. In this study, it was delivered via an iPad, and so the participant had on headphones, and they worked with the intervention on an iPad in a private room in primary care. It's modular, which means that there are different, it addresses different conditions. So someone who met criteria to participate in the study had to have experienced lifetime sexual assault, and then they had to meet criteria for current PTSD, current alcohol misuse, or for recent experiences of intimate partner violence. And so they would receive a module that aligned with PTSD, drinking, or IPV. And if they met criteria for all of those conditions, then they could choose which module they completed, or they could do all of them. And so this sort of diagram gives you a sense of kind of the flow through the intervention. And you can see the script at the bottom of the slide that it starts with when women are oriented. In this case, this is the PTSD module, to what they're going to be viewing for the next 20 or 30 minutes. She starts with a baseline assessment of the health condition, so PTSD symptoms, and then the participant receives feedback about where they are in terms of their symptoms. How high are they? Are they similar to other women veterans, etc.? There's psychoeducation that's given. There are questions aligned with motivational enhancement and the stages of change model to help women choose the next aspects of the intervention that they want to view. So someone that is higher in readiness to change might be engaged in a goal-setting exercise. Someone that's lower might be engaged in a pros and cons exercise. And in this case, this is showing you the IPV intervention. They might be engaged in a safety plan at the end of their participation. Here you can see a little bit more detail of the components of the intervention. And so this shows you some screen captures of some of the imagery and the videos. The videos we either filmed with actors, or we had permission to borrow videos from Make the Connection. And so the videos depicted real women veterans or actors telling stories about how alcohol or PTSD or IPV impacted their lives, treatment they use, positive outcomes. Again, there's motivational strategies throughout, and this is based on the stages of change model. There might be a safety plan or goal setting depending on the health condition. Everyone receives referrals and assistance if they need it, and there are kind of like empowering messages embedded throughout. So here's a little bit of the design of the RCT. So we compared the SHE intervention to a screen and referral only control condition. Everyone at the end of their participation of the intervention session received the same handout of referrals. So whether or not they were randomized to SHE or control, they got that handout, and they were also asked at the end of their session if they wanted assistance connecting with referrals that day. And they all knew that they could call if they wanted a referral later, because that was on their handout of referrals. The primary outcomes of the RCT, we were looking at two things. First, we were looking at a change. We called this health risk, but essentially it was kind of yes or no, crossing the clinical cutoff of screening positive for PTSD, recent experiences of IPV or alcohol misuse, or scale score changes on those measures. And then our second primary outcome was treatment initiation and utilization. Secondary outcomes were participant satisfaction with both the intervention and the software. Inclusion criteria I've already reviewed with you, which is that so this was in a women's primary care clinic sample, and this we exclusively enrolled participants who self-identified as female gender, and they had to have a history of lifetime sexual assault. and one of the current health risks, and you can see our measures listed here. I do want to note that for our treatment outcomes, our treatment initiation and utilization measures, we used both a coded chart review and self-report. So the chart review, of course, did not capture care outside VA, but the self-report would have. So here's a little bit about the demographics of the randomized sample. We ended up enrolling 153 women in 17 months of recruiting within the clinic. The mean age was 43. We were able to achieve our goals of enrolling a highly diverse sample who 10% identified as either lesbian or bisexual. The majority were a racial or ethnic minority, and you can see those numbers there. Only 35% of the sample was white, which was our goal. And you can see mean scores for PTSD and the audit and recent experiences of IPV. This was a highly symptomatic sample. In terms of sexual trauma history, you can see that most had experienced assault in adulthood and particularly in the military, with over 50% having also experienced or having experienced assault in childhood. I'm presenting the feasibility and acceptability outcomes first today, even though they're secondary outcomes, they're kind of necessary to sort of, understanding these results. So the study was feasible in that we enrolled our target sample in 17 months. Follow-up completion rates were really good at 85 to 89%. And those women who completed the intervention condition were in general satisfied with the software and with the intervention itself, and you can see those here. Ratings were all at the high end of the scales for each of these measures. And for our primary outcomes in the intent to treat sample, there was no effect of the SHE intervention on scale scores or clinical cutoff for PTSD, alcohol misuse, or IPV during the 4-month follow-up. However, at both 2 and 4-month follow-ups, women in the SHE group had higher rates of treatment initiation and utilization, both measured by CPRS chart review and by self-report. And so you can see those here. And then we also conducted analyses where we adjusted for baseline service use, and receiving the SHE intervention compared to the control group was associated with greater odds of being classified in a higher level of treatment receipt than they were at baseline when they entered the study. So I have a table here that shows you those baseline adjusted analyses. This is the full table so that you have it in your slides if you're interested. But what I'd like to do is hone in on the effect that is really driving our significant result in these baseline adjusted analyses, which is here. So this is the group at baseline who were in the never having used mental health services group. And you can see the left-hand columns show you the chart review findings, and the right 2 columns show you the self-report findings. And what you're looking at from baseline to follow-up is you see in that first row, the control group, there's not a lot of change. So there's about 29 women who had never used services at baseline, and that goes down to 22 at follow-up. Same thing in the self-report, there's about 22 who had never used, and that goes down to about 19. But in the intervention condition, that's where the action is. So we have 25 women who reported never using mental health services at baseline, and that's down to only 10 at the follow-up. And same thing for the self-report data. There are 17 women who reported they had never used mental health services, and that's down to 10 at the follow-up. And so that's the driver of our significant effect there. So we're seeing that fewer women had never used care by the end of the study who had received the intervention. in order to understand the clinical analyses or the lack of finding, we did do some completer analyses to sort of look at women who just received the SHE intervention. Was there any evidence of change if they used more care? And so what we did see is that those women who used more treatment over the follow-up period evidenced greater reductions in their PTSD, so almost a 10-point change in PTSD symptoms. And also reductions in IPV experiences as well. And so in conclusion, results showed feasibility and acceptability of SHE and some promising results for mental health treatment utilization, and maybe for clinical change in a diverse sample. You know, really this work, we believe it shows the potential. First, it's not necessarily this intervention per se, but the potential for a digital intervention like this to become a model for screening and intervening to address barriers to treatment engagement for a variety of conditions. And these types of interventions can potentially be leveraged in an organized healthcare setting to immediate digital connection to treatment referrals and so forth. And so we believe that these types of interventions for stigmatized populations may go a long way to overcome barriers like rape myths and systemic racism that interfere with treatment utilization. There's several limitations to this study. It was our first RCT of the intervention, and those include power. We were only powered for a medium effect size, but most behavioral interventions have a small effect size, and we think that that may have to do with making it hard to detect clinical change if it's apparent. We certainly were not powered to test mediation. 4 months is a really kind of short follow-up if you're looking for mental health symptom change. And we also didn't code for receipt of evidence-based treatment, which would be important to understanding symptom change. And in the future, we have applied for funding for a multi-site hybrid type 1 trial to kind of resolve these issues with longer follow-ups, powered in a larger sample for mediation models. We're going to change our measures to better align with VA clinical reminders. The next version of the study will deliver SHE online, and we're expanding modules and hoping to do that with active duty and other populations. And we have also applied for funding to develop a men's version. The publications for this study are out. There's an open trial that we conducted that I didn't talk about today, but that's out, and the RCT primary outcomes are out in JGEM. It's open access, so the links are here for you, and they would be accessible right away if you want more detail on this study. So I'll conclude my remarks, and I'm going to pass control of the slide deck over to Ursula now. And Ursula, you've got it.
Thank you so much, Suzannah. I just love that project so much. So let me tell you all about Project Stress Less. And if I slip into PSL, that's our acronym for it. I also want to acknowledge my team, which it reflects just an amazing group of people from the Atlanta VA, from the Portland, Oregon VA, VA clinicians, a really interdisciplinary team, including psychologists and psychiatrists, not surprisingly, but also a cardiologist, a sleep scientist, bench scientist, statistician, and best of all of the women veterans who participated in this study. This study was funded by HSR&D, as was its precursor, through a funding mechanism that's actually been retired. So PSL is a huge study, actually. It's pretty complicated, lessons learned there. So the purpose of this study was to evaluate the effectiveness of trauma-centered, trauma-sensitive yoga, or TCTSY, compared to gold standard psychotherapy, in this case CPT, with women veterans with PTSD related to MST. We had multiple aims. The primary outcome was PTSD symptom severity, but additional outcomes included psychological and physical symptoms, including chronic pain and insomnia, among others. We also examine quality of life and social functioning because, of course, those are the ultimate goals of treatment. And we're also examining the mechanisms of action of yoga. That's where you see primary aim 3 there. So I have a boatload of data. What I'm going to present to you today is primary outcomes related to PTSD, and then depression, which was not, for which we had some surprising findings, let me put it that way. But I'm going to really try to focus or highlight issues around study attrition and treatment completion. This is a very dense slide that includes the key design and components and details of this study. As I said, it's a pretty complicated study, as you can imagine from the aims and the timing of the study. This initially was a one site in Atlanta, 4-year RCT. We added Portland in year 4 to increase enrollment, and ironically, I would say to diversify our sample. So enrollment started in Portland in early 2020, like January, February, and then COVID hit. So all study procedures and interventions in both sites went virtual. So we had our last cohort going in Atlanta at that time. So that ended up being hybrid. They were halfway through in-person visits, and then we switched to virtual with a 2-week lag while we figured out how to do that. And then one large cohort in Portland, and everything there was virtual in terms of interventions and data collection. Data collection for the whole study was baseline through 3 months post-intervention. I'm doing a phase 2, which I'll talk about later if time allows. The interventions were group delivery, weekly, delivered in person and then virtually, as I've said. The measures listed here are only those for which I'm presenting data today. There are many, many others. And then we used MLM, and we looked at between group differences in this study as opposed to within group. So there are 2 interventions. The photo here where you see yoga mats, that's actually a photo from one of our rooms. TCTSY is in this study being treated as a clinical intervention for PTSD using yoga. The take-home point here is that it is not yoga for well-being or yoga as a lifestyle or yoga for some other non-specific reason. And CPT, you may all be familiar with or have heard of it. It's gold standard psychotherapy for PTSD in the VA. There are other psychotherapies that are also gold standard. Both of these interventions were actually initially developed for survivors of sexual trauma. For TCTSY, it was women with chronic PTSD who had experienced childhood sexual abuse. And for CPT, it was women who had experienced adult sexual assault. So why yoga? So some of you have heard me present before and say that I didn't select yoga because it's groovy. I do think it is groovy, but the theoretical basis for this study is that physiologically, sort of from a PNI perspective, is that yoga may be the antidote to PTSD, to what happens in the body with PTSD. Yoga may have exactly the opposite effects. There's a citation at the end of this presentation for those of you who are interested in reading more about that. There's a fair body of literature. We're still at the theoretical stage with that, which is why I have the mechanisms of action aim in the study. So that's why yoga, why TCTSY? So again, because it's a clinical intervention for complex trauma or chronic treatment-resistant PTSD. It's theory-driven. It's based on trauma theory, attachment theory, neuroscience, hatha yoga. In short, the theory is that trauma happens to the body first. So this is a body to brain intervention versus a brain to body or a cognitive approach. So kind of facilitating healing via the body rather than via thoughts. What this does is just provide a different pathway to healing for those for whom cognitive therapy is not effective. Here are the demographics. What I'll highlight here are, again, the Atlanta sample was the primary site, and so we had a sample size of 103. And then in Portland, 28. That's the intent to treat sample. So total, we had an intent to treat sample of 131 women who were randomized. That's down from an enrollment of 200. I'll talk about that in a moment. Interestingly, the mean age in the two samples was really similar, 47 to 48-year-old women. Most notable, and not surprisingly, in Atlanta, our sample was 90% African American or Black, which as an aside is very atypical for yoga studies and actually really exciting because what we saw is that it was acceptable and effective, which is, at least in the South, has been a big question that people had. There are also significant income differences between the samples, with significantly higher income in Portland. So the data that I'm going to present today includes some Atlanta-only data and some collective results, and I'll try to be clear about which is which. So here, these results are just from the Atlanta sample, so 103 women. The graph on the left illustrates the PTSD and depression symptom severity of the Atlanta sample at baseline. And what you see is that their symptoms far exceeded clinical thresholds for screening and diagnosis of PTSD and depression. On the pie chart, you see that half of the sample had severe depression at baseline, and an additional third had moderate depression. Only 5% of the sample had minimal symptoms, meaning they would screen negative for depression in the clinical setting. So the comorbidity is 95%. So this was an RCT. We kept our exclusion criteria as minimal as possible to ensure that we were mirroring the real life setting, the clinical setting in which I work, as much as possible. And so suicidality was not an exclusion criterion. And what we found is that 1/3 had been suicidal in the previous month, and 1 in 4 had attempted suicide in their lifetime. So this cyber seminars is really about treatment engagement, and attrition is the opposite of engagement. For these Atlanta data, what we see is that we had 1/3 attrition from screening to attending baseline visits. Now, some of those were excluded because they didn't meet the criteria, but many just did not follow up with us. This has implications for research as you're thinking about sample sizes, et cetera. What's clinically important is that attrition from randomization to treatment, so once people were randomized, how many people did we lose who did not ever show up for an intervention session? Attrition was 10% for TCTSY and 20% for CPT, which is, unfortunate, but supports the rationale for the study in the first place, which is high dropout rates related to associated with CPT. So the PTSD results I'm going to show you reflect data from both sites, all cohorts. We assessed PTSD using the CAPS and the PCL. For those of you who aren't familiar with those, the CAPS is a clinician-assessed PTSD symptom scale. It's gold standard, and the PCL is self-report. So this slide shows group changes over time. Our statistical analysis compared change between groups from baseline to 3 months post-intervention. And what we found is that both groups improved significantly, both clinically and statistically, which is fabulous. Like, to me, this is a beautiful picture. I could frame it and put it on my wall. There were no statistically significant differences at endpoint, which essentially shows us, though to me, they look a little off, but they're statistically no significant difference. So we see that they were essentially equally effective. Where we do see differences is in the symptom trajectory. So that on the left, the salmon color, that's TCTSY, you see them improving by more than 10 points by midpoint. And midpoint for TCTSY was after 5 weeks. Very few people, if any, actually attended all 5 sessions. So that means somewhere between 1 and 5 or 4 sessions, they had that much clinical improvement in symptoms. CPT also improved, but at a slower rate. The other thing to note here that's important about the symptom trajectory is that yoga dropped quickly, continued to drop, and then leveled off, and maybe even started to creep up a little bit by 3 months post-intervention, where CPT had a slower progression, but it was steady, and really did end up with more improvement by 3 months post. This slide just illustrates the change scores, which can, from baseline over time, which can give a different view of the data. Rather than the mean scores on the caps, we see change scores. The dotted line, the blue dotted line, is a 10-point drop on the caps, which is considered clinically significant change. And so you can see that by 2 weeks post-intervention, the yoga group was there and they stayed there. In CPT, that improvement didn't come until 3 months post-intervention. And that it remains a question about sort of what that mechanism is exactly. This is the PCL, and you see sort of a similar, quite beautiful, I think, downward trajectory and symptoms for both groups, supporting the effectiveness of CPT in the first place, and then also of TCTSY. What's interesting here in this slide is PCL is self-report. And so you see the yoga group, that's a similar trajectory. In here, the CPT group, by their own assessment, they're not really getting better by midpoint. And that may be something that contributes to dropout. If they don't think they're getting better, then it would, it's harder to stay in a treatment that you don't think is working. So earlier in the introduction, I said 60 to 72% of people who complete trauma-focused therapies still meet the criteria for PTSD after completing treatment. What we see here is that in both groups, half or more than half still met the criteria for PTSD at 3 months post. For yoga, it was 50%. For CPT, it was 55%. This is important because what this tells us is that neither intervention was effective for everybody, and neither intervention was completely effective. I won't spend much time on this at all, but just to show you this is what we saw on the BDI in terms of depression symptoms. What I don't know, because the comorbidity was 95%, is this a function of PTSD symptoms improving? We're going to do some more analyses to see if there's a timing involved, but we may not really be able to discern if this is a confounder, or I don't know, if this intervention might work for people with depression who don't have PTSD. Remains to be seen, but it's still a beautiful finding. In terms of the focus of this presentation, this may be the most important slide. So we define treatment completion. Again, these are Atlanta data only. For TCTSY, it was attendance at least 7 out of 10 sessions. And for CPT, it was 8 out of 12, which is consistent with the literature. So treatment completion for TCTSY was 60%. In CPT, it was 38%. I almost didn't want to move off that slide, but I'm running out of time. So limitations, attrition in this study was high, not a surprise. Neither intervention was effective for everybody. And again, not time to go into it, but the last Atlanta cohort and the one Portland cohort occurred during the first few months of the COVID-19 pandemic, and in the context of the political election, campaign and election, the racial justice movement, and climate change events. And remember, this is Atlanta, Georgia, and Portland, Oregon, 2 cities that were directly impacted by many of those things. So sort of to summarize, TCTSY resulted in equivalent improvement in PTSD symptoms as CPT 3 months post-intervention. TCTSY had higher retention following randomization and higher treatment completion than CPT, though the symptom trajectories varied, which I think is worth a deep dive. And co-occurring depression symptoms improved significantly. So the implications of this really are that TCTSY is an additional option for treatment of PTSD related to sexual trauma. And I say that with as much emphasis as I can. There's no part of me that thinks that this should replace our current evidence-based treatments. It's really important, I think, to have options for those women for whom the existing treatments are either unacceptable or ineffective. I think that may lead to increased initial and sustained engagement. We offered a crossover in that people who did one intervention could cross over to the other. And we had some people who did yoga and then crossed over and completed CPT, and a few that did the opposite. In terms of future directions, my hope is to obtain funding for a multi-site hybrid implementation science / effectiveness study. Whether it's a type 2 or a type 1 will be determined on how I decide to pursue looking at TCTSY for male veterans with MST and for non-VA using veterans. Here are some publications that are pertinent to the study. And there we are. So I think here is where, Heidi, if you could pass it over to Jennifer, I think she's up next.
I think my mail is here, so we'll see. My dog just put me on red alert. That was fantastic, both of you. And I have notes all over the place. So my role is to try to, with my sort of VACO policy hat on, provide some thoughts and feedback about how these results align with kind of the way we're thinking about things and strategic priorities, and that sort of thing. Let's see, I really do have a lot of notes. So first off the bat, one of the things that strikes me is that the topics for each of these align very nicely with congressional interest. So we have congressional interest right now, for sure, in women veterans, mental health and physical health, in complementary and integrative treatments, in the use of peer support, and in finding ways to engage veterans who aren't, of course, already using VA. And that's particularly a challenge with women. And there is a lot in the news, it's been ongoing, about at least a subset of women feeling not welcome or perhaps not even safe coming to a VA facility. And that is something that's sort of unique for the most part to our women veterans. I wish that we had qualitative data because I have more questions than I probably have comments. Let's see, first, congratulations on very good study names. I love them both. My colleagues and I used to hang out at lunch and try to think of good acronyms for study names, and you guys nailed it there. Let's see, starting with Suzanne. Or Suzannah. So a few things. One, I am very, what's the word? Intrigued by the change in engagement following what sounds like a pretty, not simple to design, but on the kind of a low touch, relatively low touch intervention, that you saw that much engagement in treatment afterwards. That's kind of stunning to me. And I think is something that we just need to learn how to be better at. We do need more tools to do that. I think, around sexual trauma for sure, that's for many reasons, and all the reasons you named, that's a group that, has its own hesitations, many, in the community and within VA about seeking treatment, but also for our women. So there's an overlap, but a distinction between making sure our care is trauma sensitive versus gender sensitive. So both of these presentations focused on our trauma populations, but there's also this ongoing piece of how do we let women know that VA knows how to take care of them, and that that we can tailor treatment or shape treatment in a way that addresses their needs. So both of you also did a beautiful job on that front. I would love, Suzannah, in terms of qualitative data, I would love to hear, when women talked about being satisfied with the intervention, and that you had a related outcome. It would be great to get some, interview folks and find out what it is about that, the intervention that spoke to them. Was it, for example, the, kind of the motivational approach? And this is my suspicion or my hypothesis, is that at least a piece of it was the incorporation of videos of their peers. That I think the use of videos or anything that engages women in a way that shows them that their other women veteran peers had been down the same road, have successfully recovered, have had a good experience with VA. I think that's really powerful. So that's sort of that's my hypothesis there. At least that being part of what the kind of active ingredient there is. Okay, looking at the clock and shifting over to Ursula. Okay, so full disclosure, I am a yogi. I have actually not practiced for about 2 years because I had a complicated shoulder injury and surgery, so I'm still easing back into it. But prior, practiced yoga for about 20 years. So it is, so I guess I have probably more opinions about yoga than average, and I miss it. There is, there again, there's trauma sensitive, there's gender sensitive. I think broadly, I don't know enough about the particular protocol for trauma sensitive yoga. And I understand that for research, we need to have, there needs to be something that's manualized and kind of standardized. I wonder if yoga well done would have a similar effect. And I mention that because I just think about the scalability of ensuring that folks are certified to do a very specific type of yoga per site. I wonder if that's a necessary ingredient, or if getting together, interestingly, on a VA campus. So you guys got women to show up to VA, but again, both of your arms, Ursula, were group settings, and the yoga was with peers. And the fact that you retained so many who started the group, I think you had 10% dropout over, a 10% dropout over a 10-week intervention is staggering to me. So there again, I wonder if and I agree with you, I don't think we even know that we need to tailor our evidence-based treatments for trauma for women, but we for sure know that not everybody is ready for those treatments, wants them, they're not always acceptable. So I completely agree that this is a way maybe of engaging women, getting them used to just meeting other women veterans, having a good experience with VA. And in addition to sort of the proprioceptive effects of yoga, I think you just have basic things like behavioral activation and mastery. It's a type of meditation. And I do think that there may be something in particular about women feeling comfortable in their skin who use it. I also wonder if women, how often they practiced and if they kept it up afterwards. So let's see, I will wrap myself up here. So in all cases, I think I'd love to know more about what it is that spoke to the women who completed the studies and had a good experience. I love that you're both looking at things like engagement and satisfaction. I almost think learning more about how we do that is more important than seeing symptom change, because part of the issue is just getting them in the door and having them stick and feel good about working with VA. And I love the idea of meeting people where they're at and somehow incorporating peers into the treatment experience. I think that's an underutilized tool. All right, I am going to turn my camera off and be quiet so that at least we have a little bit of time for questions.
Thank you so much, Dr. Strauss. That was amazing. I found myself jotting notes as well with sort of your lens in sort of absorbing some of the findings from the two studies. And thank you, Dr. Kelly and Dr. Creech, for your work. I do not see any questions that are specific. I do see questions about being able to handle the download the handouts, and I'm hoping our CITR folks can help figure out how folks can get access to the slides.
Yeah, Adrienne, I'm just going to interrupt for a second. I'm not sure what's going on, but I'm testing that link. I've tried it several times and it's working fine for me with no issues.
Yeah, no, hopefully we can figure that out. Or if there aren't any questions, I wonder if our speakers, Dr. Creech, Dr. Kelly, Dr. Strauss, do you all have any reactions, Dr. Creech, Dr. Kelly, to what you heard Dr. Strauss talk about?
This is Ursula. I'll jump in. Thank you, Dr. Strauss. I did know that you were a yogini, and you have a really great perspective. And thank you for the reminder, because I do have qualitative data, so I guess I better get that written up and put out there in the world. And it also including information about how often they practice, did they keep it up, etc. I think your question about the scalability and what type of yoga, would any yoga done well be just as effective? That's an incredibly salient question. I think the answer to that is, what is different about TCTSY is that it addresses the components that people who have experienced sexual trauma, the features that might get in the way of them taking advantage of any type of yoga class, whether it's at the VA or in the community, in terms of really learning interoception, having the experience of taking effective action with their body, of having choice. And so once they learn that when they go into another yoga class, they can make choices about what they do and don't want to do. So whether that's provided through TCTSY or another modality, that component of teaching what they don't have, which is the experience of choice with their body, will be what's necessary to make enable them to take advantage of any type of yoga class done well.
Thank you, Dr. Kelly. Dr. Creech.
Yeah, thank you so much. We did not collect qualitative data in the RCT. We kind of did that work in the earlier open trial phase, but I don't know if it necessarily, because it was so focused on the software and sort of the experience and the specific content elements. I don't think it got at the more holistic question, but I would have to go back and look at it through this lens, and I absolutely agree about the connection to peers, and I think these types of digital technologies can be one way to bridge that gap.
Well, thank you all. I see we're at the top of the hour. Certainly, these are creative interventions that both really lend themselves to improving mental health symptoms, but also, as we've all talked about, treatment completion, right? And so I agree with Dr. Strauss and with you all that we need to understand further sort of those mechanisms of change, and qualitative might be the way to go. We look forward to more work and what's next for you both. I'm going to hand it over back to CITR to close us out.
Great, thank you so much. I want to thank our presenters today. We really do appreciate all the time that you put into this session. For the audience, I'm going to close the meeting out in just a moment. When I do, you will be prompted with a feedback form. We really do appreciate if you take a few moments to fill that out. Thank you everyone for joining us for today's HSR&D Cyber Seminar, and we look forward to seeing you at a future session. Thank you all.